Hello friends, in the last video I had talked about how to identify right ventricular hypertrophy on any given ECG, and today in this video we are going to discuss about how to identify LVH on a given ECG. So there are so many voltage criteria to identify LVH, but the most commonly used one is Sokolov-Leon criteria, that is S wave in V1 plus R wave in V5 or V6 more than or equal to 35 mm is good enough to identify LVH. So there is one thing that you have to remember is the voltage criteria must be accompanied by non-voltage criteria. So what are these voltage criteria? Let's look at those. So in limb leads, R wave amplitude in lead 1 plus S wave in lead 3, it has to be more than 25 mm, and R wave in AVL, the amplitude of R wave in AVL has to be more than 11 mm, and R wave amplitude in AVF more than 20 mm, and S wave amplitude, that is the depth of S wave in AVR, has to be more than 14 mm. So these are few limb leads voltage criteria for LVH, to identify LVH. So in precordial leads, the R wave amplitude in V4, V5, V6, if it is more than 26 mm, you can call it as LVH. The R wave amplitude in V5, V6 plus S wave in V1 more than 35 mm, this is Sokolov-Leon's criteria. That is its most commonly used. And or in precordial leads, largest R wave, that is the largest amplitude of R wave plus largest S wave in any chest leads, that is V1 or it could be any chest leads, if it is more than 45 mm, we can diagnose it as LVH. So these are voltage criteria, and this has to be accompanied by non-voltage criteria. So what are these non-voltage criteria? Non-voltage criteria includes increased R wave peak time more than 50 milliseconds in V5 or V6. This is one of the non-voltage criteria, and there has to be presence of LV strain. What is this LV strain? LV strain is nothing but ST depression and T wave inversion. ST depression and T wave inversion. ST depression and T wave inversion. So these are non-voltage criteria. In lateral leads, ST depression and T wave inversion in lateral leads, that is 1 AVL, V5 and V6. So what are the causes of LVH? See, look at here what happened in this diagram. This is pictorial diagram of showing LVH. So this is normal heart. See, there is normal chambers and normal thickness of the left ventricle. So what happened here? Thickness of the left ventricle has increased. So this is the representation of LVH. And why we are seeing V1, V5, V6? Let's suppose this is your heart. This is your normal heart. So what happened in LVH? There is presence of, I am drawing only ventricles. See, there is presence of this left ventricular hypertrophy. So let's suppose this is the orientation of your leads: V1, V2, V3, V4, V5 and V6. When there is current depolarization of left ventricle, the direction of depolarization is in this way. So this electrode is going towards the V6. One basic thing that you have to remember in ECG is, if the impulse is going towards the lead, it is perceived as positive deflection, and if the impulse is going away from the electrodes, it is perceived as negative. Let's suppose this is your electrode and this current is going up towards the electrode, it is perceived as positive deflection. If same current goes away from the electrode, it is perceived as negative deflection. So anything up in the ECG is positive, anything down in the ECG is negative. So now the depolarization vector of left ventricle is going towards this V6, and this amplitude increase, so it is perceived as positive, and the amplitude is increased because there is hypertrophy of the right ventricle. One more basic thing that I want you to remember is, more muscle mass means more current. So and same current is going away from the V1, so it is perceived as negative, and the amplitude of S wave is more because it is muscle mass is more. So S V1 plus R V6, if it is more than 35 mm, it is good enough to call it as LVH. So what are the causes of LVH? Causes of LVH includes systemic hypertension, aortic stenosis, or aortic regurgitation, or mitral regurgitation, or coarctation of aorta, or it is a part of hypertrophic cardiomyopathy. So these are the causes of few causes of LVH. So uh, let's look at a given ECG and try to identify the LVH. So in any given ECG, you have to start from looking at the standardization and rhythm, rate, and axis calculation. So let's look at the standardization. It is running at a speed of 25 mm per second. This is good standardization, and 10 mm per millivolt. This is a standard ECG taken in a standard good standardization. Next, we have to see rhythm. So there is P wave, QRS, P wave, QRS, P wave, QRS. Every P wave is followed by QRS, and every P wave is looking same. Okay, every P wave is same. Every P wave is followed by QRS, and there is regular RR interval. RR interval is regular. That is 1, 2, 3, 4, 4.5 boxes. 4.5 boxes means around it is 65 to 70 is the heart rate here. So this is normal sinus rhythm. So this is normal sinus rhythm with normal rate of around let's consider it as 65, and the axis you have to see. So what happened to axis? To find out the axis, you have to see lead 1 and AVF. In lead 1, QRS complex is predominantly upward, and lead AVF it is predominantly downward. So both are leaving each other. Leaving each other means left axis deviation. There is presence of left axis deviation. Next, you have to see waves. Lead to P wave or normal QRS, there is prolongation. QRS, there is little wide complexes are there. So wide complex QRS, and there is what happened here. See, in V1 what happened here, the S wave is deep S wave. How much is deep? 1 box, 2 box, 3 box, almost 3.5. So 3 box means 15, 3.5 means around 18 small boxes, 18 mm. This is 18 mm. And in V6 what happened? There is tall R wave. See, tall R wave. So how much is the length? Amplitude 1, 2, 3, 4, 5 boxes. 5 boxes means 5 into 5, 25 mm. So what is the criteria to LVH? That is SV1 plus RV6 more than 35 mm. So here SV1 is 18 mm plus RV6 is 25 mm, which summated becomes 43 mm, which is obviously more than 35 mm. So this suggests there is presence of LVH. So and look at here what happened in V5 and V6. ST, I'll show you here. There is ST depression. See, ST depression. So what is TP segment? This is TP segment. Say there is ST depression and T wave inversion. T wave is inverted. See, this is supposed to be like this. ST segment is supposed to be this and T wave like this. But what happened here? ST is depressed and T wave is inversed. So it is seen in V6 and V5. So this is called as Elvis strain pattern. This is Elvis strain. And it is also seen in lead 1 and lead AVF. So lead 1 AVF V5 V6 are your lateral leads, and they are looking at your left ventricle. So left ventricular strain pattern is also there, LV strain is there. So all these findings are suggestive of LVH. So what are the other additional features that may be present with LVH? You may find left atrial enlargement, right? That is wide P wave, wide notched P wave, that is P wave of more than 2.5 mm in width. And you may find LAD, left axis deviation, and there may be ST elevation in right precordial leads, that is V1 to V3. So in this ECG, see, there is ST elevation in right precordial leads, that is V1 to V3. See, it was supposed to be here. So there is ST elevation. See, there is ST elevation here. So ST elevation in right precordial leads like V1 to V3, and prominent E waves in V1 to V3. See, there is prominent E wave. These are E waves. Okay. So these additional findings includes ST elevation in V1 to V3 and prominent E waves in V1 to V3. So these are the additional features that may be present with LVH. So hope you got few information about LVH, how to identify it and give an ECG. Hope you like this video. Thank you.